We're taking this, 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 we're taking with a pinch of salt.
Dear ladies and gentlemen, welcome to another episode of A Pinch of Salt, your favorite ERA podcast. My name is Andrej Kubernet. I'm a nephrologist from Slovenia. And this month, we're devoting some of our time and thoughts to the tubular interstitial realm, a field that seems to be somewhat forgotten and one that we should probably devote more time and energy into. You can check out the episode on tubular interstitial nephritis, subtitled The Cinderella of Nephrology. That has also been released this month, but in this episode, we will be talking about chronic kidney disease of unknown etiology, a most unfortunate name, in my opinion, which in principle could mean any kind of CKD where we don't know what the exact cause is. However, this particular topic, this episode, is the mysterious entity that used to be called Mesoamerican nephropathy, if you probably heard that name before. So we'll be talking about a tubular interstitial disease that primarily occurs in agricultural workers in very hot environments. And this can be an absolutely devastating disease with a very wide value of reported prevalences, but often in the range of 10 to 20%, mind you, in young men, of course, where you wouldn't expect that, working in the fields. And on other occasions, such as a particular community in Nicaragua, which some have locally named, unfortunately, the Village of Widows, as so many men die from this disease, the prevalence of CKD among men was about 40%. So this can be a complete nightmare. Some of us will probably not work with these patients because we live in different areas, but it's an interesting disease to think about. And here to talk about this is Dr. Shuchi Anand. Dr. Anand is the director of the Center for Tubular Interstitial Kidney Disease at Stanford University. And she has a particular interest in this unexplained entity and has also researched it quite extensively. So, Shuchi, welcome to A Pinch of Salt.
Thank you so much, Andrej. I'm so excited to be here. And thank you for highlighting tubular interstitial kidney disease and CKDU in particular. I'm happy to talk about this.
I'm sure you are. And I've been really excited about these episodes as well, because it's always nice to learn something new. And this will probably be the case today because most of us are not very well versed in this problem. So to start this off, can you tell us something about the so-called CKD of unknown etiology, what it actually is or what it might be, what the history is, and what are the main theories about the etiology of this disease?
Yeah, thank you. So I think the history is interesting. It goes back to clinical observation, right? That is the main historic setting through which, the sort of route through which we first recognized this particular disease. And it's similar to what's happened with other environmental toxic nephropathies, is that a astute clinician first notices something out of the ordinary. And in this setting, what happened was there was a clinician based in El Salvador who noticed, or a group of clinicians in El Salvador who noticed that there were young men coming into their clinics from agricultural communities who didn't have diabetes or high blood pressure as a risk factor for kidney disease, and they were making up a larger share of their clinic than they expected them to. And similarly in Sri Lanka, this all happened in the 1990s in both areas. In Sri Lanka, one of the first nephrologists who trained in the country and posted in the country went to a central hospital, which is serving an agricultural area, and saw that many men were coming in with end-stage kidney disease, needing urgent PD, and they didn't have diabetes. And, he was, based on his training, very concerned about what might be the cause of this level of kidney disease in that region. And so that's how it was first described. And even now we think of CKDU as a regional kidney disease occurring in three best described hotspots. The first in Mesoamerica in general, so Central America. The second in the southern state in India called Andhra Pradesh. And the third in the central area of Sri Lanka. It is still a disease considered mostly of agricultural workers. There's a debate in the field about if it's only affecting men. I think in Sri Lanka, there are reports, and in India too, that women are reasonably high number of their case counts. And yeah, most people don't have diabetes, but as populations have changed, there are some people with concomitant diabetes too. But the way that clinicians feel they differentiate it is either based on biopsy that shows primarily tubular interstitial kidney disease, or based on lack of albuminuria in a setting of, very early onset diabetes. So, or at least mild diabetes. And so, it's if we really wanted to diagnose it clinically, we would have a hard time. I think we would have to do a biopsy to have a definitive diagnosis for this particular disease.
And the biopsy is kind of specific, is it? I mean, well, it probably can differentiate between classical diabetic nephropathy for sure.
Yeah.
But this is primarily a tubular interstitial disease, and we think it's probably a toxic one with an unknown
Mhm.
toxin and heat causing additional problems. So a biopsy would help, right? It does have some particularities that might be interesting, right?
Yeah, I mean, I think there's the biopsy is mostly also, rules out phenomenons that we know about. So there is no immune complex. There's no heavy diabetes. There's no heavy arteriosclerosis. That's basic, and no crescentic lesions in the glomeruli, for example. But there may be a spectrum of inflammation versus fibrosis in the tubular interstitial compartment. There's also some FSGS described, and the range of FSGS described also interestingly differs by region. In the South Asia regions, they have more primarily tubular interstitial kidney disease described, versus in Mexico, southern Mexico, and in some of the areas of Central America, they see a lot of glomerular sclerosis as well. So they don't know if the two are occurring in parallel, versus obviously whether the tubular interstitial is primary and then the glomerular sclerosis is secondary. But the diagnosis, currently, we don't have validated biomarkers that say that someone with reduced GFR has CKDU, or has this particular type of kidney disease. I think what we need is they have to be living in the right region. They have to be working primarily in an outdoor occupation, likely agriculture, but outdoor occupation is felt to be sort of a major contributor. And then the third is, yeah, CKD that's with reduced GFR, not heavily proteinuric, and those are sort of like the probable characteristics of a CKDU person, but the definitive diagnosis would need a biopsy, right, to prove that they have a tubular interstitial underlying kidney disease. I think there's a lot of debate among clinicians about whether they need the biopsy, only because if you've seen so many people, when you're practicing in a region where you see so many people coming in with this sort of triad of findings, reduced GFR without proteinuria, no autoimmune condition, no diabetes, and they are agricultural worker and they live in that region that has a lot of kidney disease, why do they
Yeah.
need a biopsy? Because they don't necessarily have a specific clinical treatment to target the lesion. So it's a fair question. I think this is something that each clinician has to decide with their patient. Some patients, and I would include myself in the perspective, if I were in the shoes of that patient, I would potentially want a definitive diagnosis. Some may want also some prognostic information, right, from a biopsy. So that could be helpful, but I can see where clinicians who were in the earlier decades, in the early 2000s, biopsying a lot of people, now have enough experience under their belt and enough
Sure.
epidemiology under their belt to feel like they can clinically diagnose CKDU.
Sure. I'm sure when you see a lot of these patients, it becomes a bit of a no-brainer, I guess. And
Mm-hmm.
just a quick segue. So it's a progressive disease. People get to end-stage kidney disease. So what's the let's say, approximate timeline from once you find the disease and when the poor chap will be on dialysis, perhaps? What's the estimate? I know it's a silly question in a way, but are we talking
Well,
10
I think
years, 20 years, 30 years?
yeah, I think it's a great question. And it's a question that we haven't answered very well. I would say that if you look at the end-stage kidney disease counts in Sri Lanka, where people have reasonable access to dialysis care, or at least a diagnosis of end-stage kidney disease before they pass. Primarily, the folks are in their 50s, 40s, and 50s when they're reaching end-stage kidney disease. But then when they're diagnosed kind of depends on when they're screened, right? So the timeline of the disease is hard to notice. We have a case cohort in Sri Lanka in which we enrolled people from a GFR of 20 to 60 in our cohort in 2018. And I'd say a majority of those people, we had about 294 people, a majority of those people have not reached end-stage kidney disease, and it's almost, 8 years later. So, and we don't know if that's because we caught the survivors, right? Because the people who were progressing fast probably didn't have the chance to participate in a case cohort, or it's because something has changed in the region, or just the mere fact that, there's more awareness about CKDU, there's change in behavior that's allowing people to protect kidney function.
Sure.
So it's hard to know the timeline, I would say, but if someone was progressing fast, even in Sri Lanka, they reached dialysis in the 40s to 50s.
That's pretty bad, yeah.
Mhm.
So since we don't know what the specific problem is, we don't have a specific therapy, but the our colleagues that do treat these patients in Mesoamerica and Sri Lanka, how do they treat them? I mean, just the regular, I would say, CKD treatment, I guess. Do they put more emphasis on these preventive or curative measures in the sense of fluid intake? Because we know that generally in CKD, a larger fluid intake, we don't really have data that helps. But in this case, it probably makes sense, right?
Yeah, I mean, again, no evidence to support any of this. But first, let's step back to when a clinician has diagnosed as kidney disease, they have some idea of what they think the disease is from, and some clinicians may have a stronger feeling for one over the other. But the hypothesized causes are one, heat stress alone, meaning that people working in hot environments are taxing their kidneys with recurrent AKI to the extent that they're developing progressive tubular interstitial kidney disease. The second is maybe a contaminated source, contaminant being sourced to the patient through their water. So, because many of the regions rely on groundwater, there's a concern that the groundwater either has agrochemicals or metals or elements that are toxic to the kidney. And then the third is that there is potentially a nephrocentric infection, like kind of in the setting of leptospirosis, right? Where there is a new infection that we haven't yet detected that is presumably kidney tropic. And then fourth, I think, is that there is a concern of, I mean, and this can go along with all three, is that there's a gene environment interaction, that there's some people with a genetic predisposition that when they match the right environment, they are developing this kidney disease. I think of those four that I've mentioned, the first two are the only ones that clinicians can potentially intervene on an individual basis. But also communities are intervening on these on a community basis because they want to take preventive action, right? And they want to save they feel the disease is occurring at a community level. So they want to take preventive action at a community level, similar to what happened with valvular nephropathy or ischemic acid nephropathy. So for that, there are people partnering with occupation sites in Central America to do these rest water shade interventions. And so their water fluid intake is something that people are studying and or encouraging to do is fluid intake matched to the level of exertion in the field as a preventive action, I think. And then the other thing that communities are doing is changing their water supply from groundwater to either RO waters that they install in their home or get in a community plant, or advocating like piped treated water be sent to their community. And all of these interventions are ongoing on a community basis. On an individual clinical basis, when you meet someone with this disease, once they are diagnosed, I think many people, at least in Sri Lanka, stop their level of exertion that they were having previously in their field kind of on their own. I mean, the clinicians may advise that to like take plenty of rest, drink plenty of water. They don't have specific, I have not, I've reviewed many consultations that occur. I've been in the room with clinicians consulting with CKDU patients, and they don't usually offer a specific fluid intake guideline. And I think that's astute because it depends on the level of exertion in the heat, right? That you don't want people to drink to the level of hyponatremia as well. So they say just reduce exertion, drink plenty of water, and have shade. They also ask them to protect themselves from agrochemicals. So wear protective gear while spraying agrochemicals. Those are sort of non-pharmacologic interventions that they prescribe. And then they also, in terms of pharmacologic interventions, I think they would avoid diuretics. That's something I've seen consistently, is that they tend to avoid diuretics for blood pressure management, unless there is significant hyperkalemia or volume that's evident. I have not seen HCTZ as a drug, as first line for anything there. They would rather use ACE inhibitors, even that, very, very cautious, very low dose ACE inhibitors with caution. And they use SGLT2s, at least in Sri Lanka, they use SGLT2s. Those are the two that I've seen more, protective measures being prescribed. Yeah, and I think that's very reasonable. A colleague of mine and I just we're preparing something for NDT for clinical management of CKDU. And we just did a lit search to see does this actually make sense? And it does, based on the data that we have from RAIN and ASK, it makes sense to potentially use ACE inhibitors even in people without proteinuria, as long as they have reduced eGFR and hypertension. And some of the data from DAPA-CKD and other studies, there were people enrolled with lower albuminuria, less than 300, in the 30 to 300 milligram range, and they also still experienced, at least directionally, benefit from SGLT2s. So both of those strategies could, on an individual level, make sense. And it will also make sense to avoid diuretics because you're uncertain of their physical exertion.
Yeah. That all sounds very reasonable. It's nice of you to portray I almost felt like I was in Sri Lanka listening to the consultations. Thank you. That was very nice.
And I mean, even, when you think about yes, these are marginalized communities and they are affected by kidney disease that's devastating. But in some regions in the world, they still get great care because of the way that their public health infrastructure is built.
Sure.
Yeah.
So, are there any RCTs going on? Is there a lot of research that we might hope to get in the near future that would be more definitive in terms of this disease?
Yeah. So I think we kind of started to talk about this, that there's community-based interventions and individual interventions. And for the community-based interventions, not necessarily in an RCT format, but there are before and after evaluations of rest watershed interventions that show that there is less acute kidney injury occurring in the people doing the most strenuous work if they are adhering to the rest shade water intervention. So this is by colleagues in La Isla Network. They worked in a sugarcane mill in Nicaragua, where they implemented a rest shade water intervention. And so that basically means you try to provide cold water for thirst, generally encourage people to drink to their thirst and have clean, cool water available for them. You enforce mandatory rest breaks, and then those rest breaks occur in a shaded area. And the number of rest breaks kind of depends on the temperature, so that you can sort of increase the number of rest breaks if the temperature is high. And so in that setting, they looked at, before this intervention, what was the rate of acute kidney injury. I guess we have a terminology issue here, because what they mean is, what was the GFR at the start of that harvest, and what's the GFR at the end of the harvest, which could be a few months. And so those rates were reasonably high in people who were doing sugarcane cutting, for example. So they were doing the most strenuous task in that plantation. And they had a high risk of acute kidney disease across the harvest. And when they followed this rest shade intervention, those incidence rates for that type of acute kidney disease decreased by over 50%. So,
That's
yeah, so
that's
that,
very promising. That's very
yeah,
nice. Mm.
yeah. So that type of preventative intervention is something that, probably deserves an RCT, although, there'd be ethics of, because pretty much everyone deserves rest shade and intervention. So the before after framework
That's
may
true.
be
Yeah.
the best data that we have, but yeah, that one is very promising. The other is the provision of non-groundwater drinking water. So in Sri Lanka, in India, in southern India, the historic water supply has been well water that is untreated, and the depth of the wells is variable, but usually they're shallow wells, not deep into the groundwater table, but shallow wells. And there's a concern that either their own chemistry, because of their silica content, their fluoride content, their vanadium content, none of these proven, is nephrotoxic, or the fact that they are in an agricultural area and therefore could get contaminated with pesticides, that is nephrotoxic.
Yeah.
And so communities there have advocated for, either in Sri Lanka, I go there and there are Navy-run RO plants. So there's a whole setup, just like you would see in a dialysis unit, but in like next to a school, for example, that is drawing from the groundwater, cleaning the water, and that's where people come and get their daily water supply.
Wow, that's amazing.
Yeah, yeah. So that is another preventative intervention. And then some houses have their own RO, little RO filters placed in next to their kitchen sinks. So that's another intervention. There's a recent publication in BMC Nephrology which hypothesizes that intervention is perhaps why they're seeing a lower incidence of CKD hospital case counts in the affected regions.
Yeah, I mean, because the gut feeling is that there has to be a toxin involved. Of course, the gut feeling is not always right, but if you think about other places that are desperately hot, like Saudi Arabia or, Libya, and there's a lack of cases there that I'm aware of, there has to be something else, I guess.
You're right.
Yeah.
And Brazil, for example, is a
Yeah.
big sugarcane producer, and we don't, as far as we know, there isn't as much disease there,
Mm,
right? Or in areas of Africa, right?
sure, sure.
So yeah, that's the gut feeling. But there's also the gut feeling that heat is somehow playing a role. Acting on heat, or the intensity of work interacting with heat is a role, is at least an amplifier of the disease. But those are the two interventions. There is a individual RCT ongoing on use of allopurinol in Sri Lanka that I know of, and they did an RCT using doxycycline and steroids. in
Mm.
people who presented with sort of acute interstitial nephritis into their clinic. That one did not show major effects by the use of steroids acutely, at least. There was not much effect in terms of recovering GFR in
Mm.
people prescribed steroids. Long term, they reported that the GFR was more preserved in the people prescribed steroids.
Oh, okay.
So there's a spectrum of disease, and this is why biopsies may be helpful, is if we know there's a spectrum that is very acute, perhaps they need a different type of treatment.
Yeah. So we've come full circle back to the biopsies. That's nice.
Yeah.
So just quickly, because of global warming and because heat is a factor, we're probably expecting to have more and more of this problem or similar problems, right?
Right. I mean, I think for CKDU, of the three hotspots that we've talked about, we are hoping that some of these community interventions are working, right?
Yeah.
And we don't know why or what is necessarily working, but we are hoping that those regions will start to see a decline in disease. But whether globally we will see environmental toxins causing kidney disease, probably there's much
Probably, yeah.
more exposure to environment, whether that's through disasters that occur or through ongoing need for additional chemicals, for example, to prepare the field as we use up our resources. It's sort of a soil health resources. Then the heat question is also an interesting one, I think, because it is getting warmer. The temperature is getting warmer throughout the world. There are some interesting studies showing that heat raises many population-based studies that show that conducted in Australia, the UK, Canada, showing that in a heat wave, you have more people coming in with acute kidney injury. And so that
Definitely,
we
yeah.
know is likely to be a factor, especially in people who are frail and have diabetes or heart failure, for example. And there's another study that shows that in the DAPA-CKD study, in people who had diabetic kidney disease, if they were living in hotter regions, they experienced faster progression. So I think heat will likely affect the epidemiology of CKD overall. Whether it'll affect it in agricultural communities, we hope not, because we know about CKDU and we hope we can intervene on behalf of other agricultural communities.
Yeah, they'll be
Yeah,
ahead of the pack,
perhaps,
perhaps,
perhaps.
hopefully,
Yeah, yeah.
for them. Okay, that's great. We're going to go to the last question, which is more about you. So we like to get to know our guests at least a little bit, to find the person behind the science and the person behind the medicine, which is nice. And so the simple yet slightly difficult question is, which book, two songs, and luxury item would you take to an isolated place? Let's call it a desert island or whatever that may be.
Right. So I crossed two worlds. I was born in India and I grew up after I was 12 in the US. So I have some interesting. So one of the people who crosses two worlds is a writer named Abraham Verghese, who is a doctor as well. So I love his books. They reflect my experience so well. And so he recently wrote The Covenant of the Water, it's long, but it's very readable and I could read it over and over. So I would probably take that book. And then songs too, I'm going to split. I love Beyonce. I may not seem like the person, but women of my generation really find her as a great role model. So some women of my generation really find her as a great model. So I love Beyonce and I love her classic song, Halo. But then there is a Beyonce of India. You might not know, but her name is
Probably
Sunidhi
not. Probably
Chauhan.
not.
Sunidhi Chauhan has great songs, and I would take any of hers
What's
with
her
me
name?
as a
One more
companion.
time, maybe. Her name is
Sunidhi Chauhan.
Sunidhi Chauhan. Okay,
Yeah,
I'll check it
yeah,
out.
you might want to look at. Yeah, she's great. And then the luxury item, I love to sleep, and I right now a desert island sounds great as long as I'm not trapped there forever. I would love it. And I take like I was just looking up for my own Christmas list that I would love an UGG blanket. They seem very nice and cozy and soft, and I would take that to a desert island.
That sounds great. That sounds very cozy. The
Yes.
American and the Indian Beyonce and the blanket sounds like an
Yeah.
interesting
I
time.
don't know how much time I'd be spending on them because maybe I'd be dancing around too much.
Yeah. Abraham Verghese was actually mentioned by one of our guests, by Professor Stone, a rheumatologist from Harvard.
Oh, yeah.
And he mentioned Cutting Stone, I think. I'm very
Cutting
excited about
stones.
that book as well. So this is the
Yeah.
second time that he has been mentioned. So definitely a very a huge recommendation, I would say.
Two, I mean, he's a doctor and he has an immigrant experience, which is fantastic, but the books are very readable. They're very plot based, which makes them exciting.
Hmm. I think for
Yeah,
doctors, you need a readable book.
that's right.
I have no patience to go through, I don't know, Ulysses or whatever that
I did
has
that in
very
high
long
school and
descriptions of
never
stuff. Yeah.
again. Yeah. Although
Okay.
I love my philosophy podcast too.
Oh,
So,
what is
but
that?
those,
Can I ask what your
yeah.
philosophy podcast is?
Do you know about this philosophize this? Um,
Philosophize this. Yeah, that sounds familiar. Hmm.
That's a wonderful podcast. I subscribe to it. Yes, they basically take works of classic philosophers, current philosophers, even Shakespeare, and sort of distill. This person, Stephen West, sort of distills the primary thesis. And he starts, if you start from the beginning of his series, he starts from Plato and Aristotle and works all the way to modern philosophy. It's
Oh
pretty
my God,
great.
that sounds great.
Yeah,
Oh God,
yeah,
that's I'm so wow. I'm happy to hear
yeah,
this. I will definitely check that out. I
yeah,
love philosophy. We need more thinking, I think, on this planet. We're not thinking enough, it seems, at least to me.
yeah. Examine lives is what we need,
Examine
right?
lives, yeah, examine.
Yeah,
Yeah.
yeah.
Well, thank you. This has been a real treat. You really know how to explain this story very well. And I feel like I know much more about CKDU. And thank you, Suchi. This was wonderful.
Thank you, Andres, for having me. And I'm going to check out the first podcast soon. Thank you.
Okay,
On
great.
tubular interstitial kidney disease. Thank
Yes,
you.
please do that. Great. Thanks.
Thanks.